Welcome to case study number 23. This will be a patient coming in with memory loss. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button in the upper right-hand corner. I really appreciate all the contributions that I can get to help offset the cost of these videos. And I appreciate those of you who have already stepped up to help donate, and also those of you who are considering it. So thank you very much in advance. All right, we got a 66-year-old Hispanic man coming into the clinic with his wife complaining of worsening forgetfulness over the last several months. It started with him unable to remember where he placed his keys or wallet. Now he has difficulty finding his way home while driving back from the supermarket. His wife is concerned because last week he forgot to turn off the stove. He is a retired chemical engineer. He's sexually monogamous with his wife of 40 years. He rarely drinks and does not smoke or use recreational drugs. His past medical history is significant for BPH, benign prostatic hyperplasia, and hyperlipidemia. Family history is non-contributory. Medications include finasteride, atorvastatin, niacin, and CoQ10, and a multivitamin. Blood pressure 114/72, heart rate 71, respirations 12, temperature 98, setting 100% on room air. All right, so got a patient with worsening forgetfulness, and it's been happening over the course of many months. What do we need to do for our physical exam here? So we're going to do a pretty comprehensive exam. This patient is in the clinic, so we're not worried about anything acute going on here. So everything looks pretty normal. We really want to focus in, though, on that neuro and psych examination because this is a patient who comes with a primary complaint of a neurologic or psychiatric problem. So we find neurologically he's alert and oriented. That's important. He's got no focal deficits. That's going to be really important, too, as we progress. His deep tendon reflexes are intact, normal gait, and no tremor. Psychiatrically, what we're doing here is a mini mental status examination. You can look that up. He's got decreased ability in naming objects and doing calculations and poor 5-minute recall. Okay, so what is our differential? We need to consider all of the possibilities that can lead to dementia. So number one is Alzheimer's. You got a patient with dementia. About 75% of them are going to have Alzheimer's. So that should definitely be at the top of our differential. Number two, we need to consider the possibility that maybe this is just normal aging. And we'll go into how we can differentiate normal aging from actual dementia in a little bit. Frontotemporal dementia, vascular dementia, pseudodementia, which is associated with depression. Very important to get that psychiatric examination. Lewy body dementia, associated with movement symptoms. Chronic subdural hematoma, common in older people. And then some medical causes, hypothyroidism, tertiary syphilis, B12 deficiency. So what are we going to do for our workup? This is so important. So our workup is for dementia, for the possibility of dementia, is always going to include these 5 things. We're going to get a CT of the head. We're going to get a TSH. Remember, hypothyroidism can cause this kind of picture. We're going to get a serum B12 looking for nutritional deficiencies. We're going to get a VDRL. Who knows? Maybe he had syphilis a long time ago, never got it checked out. Maybe he's got tertiary syphilis. Long shot, but we should include it. And then we're going to get a depression index. Okay, so you should know that when you're working up dementia, get a CT, TSH, B12, VDRL, and screen for depression. Always, always, always. Because these will all, this will rule out all of the possible reversible causes of dementia. Okay, so what do we find? We find mild cortical atrophy and periventricular leukomalacia, no evidence of bleeding. The TSH, B12, VDRL, and depression index are all normal. So we've got a patient with dementia and normal labs, with the exception of that head CT, which shows some degenerative changes. So what we can do now is make the diagnosis of Alzheimer's dementia. Alzheimer's is a clinical diagnosis. So what we need to do is we need to exclude other causes, especially the reversible ones. Pseudodementia associated with depression, hypothyroidism, we ruled that out with the TSH, B12 deficiency, we ruled that out with the serum B12, neurosyphilis, we ruled that out with the VDRL, and NPH, which we weren't really considering in this patient, but you would be able to rule it out with a CT. The treatment for Alzheimer's, because this is an issue with acetylcholine, we want to give cholinesterase inhibitors to try to increase the acetylcholine in the central nervous system. The medications that we can give for that are donepezil, rivastigmine, or galantamine. Any of those are going to be the correct answer on CCS or on a multiple choice question. Now, as the condition progresses and it invariably progresses, then we add on memantine, which is an NMDA antagonist. It's also known as Namenda. So we advise the patient to get an advance directive, counsel and reassure, and then we refer him to neurology for long-term management. So Alzheimer's dementia, what is it? Well, first we need to understand what dementia is. Dementia is a progressive impairment in cognition that impairs, and this is important, impairs the patient's ability to take part in everyday activities. So when the patient was just having difficulty remembering names, maybe misplacing his keys or wallet, that's pretty common in older people. Heck, it's pretty common in younger people too. But when this started to affect his everyday activities, he's having difficulty finding his way back from the grocery store. He's leaving the stove on. Maybe he's forgetting his grandkids' names. Things that you just don't see in normal people. Then we begin to think of different causes of dementia, Alzheimer's being number one. So Alzheimer's presents as an older patient with a long history, several months, of memory loss, and then other features may present as well. If you do the mini mental status examination, what you'll find is there are particular problems with recall, language, and attention. The diagnosis of dementia is clinical and reversible causes must be ruled out. The essential workup is the CT, the B12, the TSH, and the VDRL. The treatment is to increase acetylcholine availability, so we give cholinesterase inhibitors, and memantine is added late. There is no cure. What about dementia or dementia appearance in a younger person? Well, we need to consider HIV-associated dementia, so we would get an HIV test. Huntington disease, look for a family history, as well as those movement symptoms, choreoathetoid movements, that's like hemiballismus and stuff like that. Normal pressure hydrocephalus, particularly in women, wet, wobbly, and wacky. Creutzfeldt-Jakob disease is rapidly progressive, and so look for just a really fulminant decline in cognition over the course of a few months as opposed to several months to years. Common differentials, normal aging. So this is just occasional forgetfulness, maybe difficulty remembering names of acquaintances, difficulty finding words, and you get the words on the tip of your tongue. Maybe occasionally they'll lose their keys or misplace things, but it does not impact their daily life. It may be a minor annoyance, but it does not impact their ability to do basic things. Frontotemporal dementia, personality changes. Bruce Willis was just diagnosed with this. It started out with aphasia, presumably went on to be personality changes and forgetfulness. Vascular dementia, look for this stepwise progression. So they're fine for quite a while. They've got certain symptoms, and then suddenly, a few days later, they're worse off, and then they go a couple years like that, and then they decline more. As opposed to Alzheimer's, which is this continuous progressive decline. Pseudodementia, look for depressive symptoms. The patient's often withdrawn. Lewy body dementia, look for Parkinsonian symptoms, movement symptoms, rigidity, bradykinesia. Chronic subdural hematoma, look for focal symptoms. Remember, an Alzheimer's patient will never have focal symptoms. You can rule that out with a CT. Hypothyroidism, look for multisystemic symptoms. You know your hypothyroid symptoms. Tertiary syphilis, they tend to have sensory defects, tabes dorsalis, gummas. And vitamin B12 deficiency, look for a history of alcoholism, poor nutrition, anemia. So to recap, Alzheimer's is the leading cause of dementia in the United States and should be suspected in an older patient with progressive forgetfulness and cognitive impairment that interferes with activities of daily life. Remember to exclude reversible causes. Get your CT, your B12. You want to get a VDRL, a TSH, and a depression screen. The management for Alzheimer's is cholinesterase inhibitors, ribostigmine, galantamine, and donepezil. Memantine is added late once they stop responding to those cholinesterase inhibitors. The management includes primarily referral to a neurologist and or psychiatrist because they will start to have complications, including insomnia, depression, and psychosis. You will not be asked to manage that on CCS, but you should know that those are certainly things that will happen in the long term, and so they should be referred to neurology for ongoing long-term management.